Hello, everybody, and thank you very much for being with us again this evening. Today, I thought I would talk to you about the practical aspect of endoscopic ear surgery, really with the steps and the setups and the operating room, and the different ways that you could use the endoscope to enhance your access into the diseased area. Again, welcome everybody, and we will start the presentation. First thing I want to say is that I really would like you to consider getting the app. And the main reason for this is that, you know, in the future, we're going to have a very, right now we're doing it every day and at 5 o'clock, but we really, in the future, we're going to be doing it in a different time periods. And I just want to make sure that, sorry, get the slide back. So I just want to make sure that you guys keep updated. You know, we're going to be starting surgery sessions, live surgery sessions. So also you need to, for the live surgery sessions, there is really a limited access and you need to register. This is because of local regulations. So it's a way for us to communicate. We will send you a notification when there is any change in the program. You could very, very easily get to see what's going on. So please go ahead and download the app on your mobile. Again, if you're reaching us now with a computer, you could take a picture of this QR code and it would launch, the download would launch automatically. And if you are reaching us with the mobile, I have sent on the chat the link for the download of this app. So again, please go ahead and do that. So basically, just going to talk about, I had talked previously about the setup about the principles of endoscopic ear surgery. So today, what I would like to do is talk about the practical aspects of endoscopic ear surgery, the setup of the room, the instruments, and the way you carry on the procedure. So this is something that I'm very mentioning it constantly because it really makes a huge difference. And this is a natural orientation. This is, of course, a coronal view. This is a natural orientation of the ear canal being upsloping. So again, one of the great advantages of the endoscope is the ability just to turn the endoscope this way and get a very, very different view. So you really don't want to start like this. You want to start at a right angle. So it really is very important to bring the ear canal into a right angle. And this is what I usually do, is that I ask the nurses to place the headrest sort of the wrong way, so the head could fall into that area. And I pull on the hand and I use a towel, a green towel, to fix the hand, tuck the hand in place. So I like this, the shoulder neck angle to be around 120 or 130. So it would basically gives you an ability again to turn the endoscope this way and that way and really have a great access into the attic. So in terms of instrumentation, please, if you're using the short endoscopes, it's not going to work for you. I have basically, for much of my career, used the 4mm 0-degree endoscope. I was, again, for much of my career, pretty much against using angled endoscope. But if I have to point out one big change in the way I do things with endoscopic ear surgery, it is the fact that I'm using the 30-degree endoscope, I would say, in about 60% of the time. And it really is, gives you a great access into all the different spaces of the middle ear cleft. But if you are using a 30-degree, and you cannot use a 4mm 30-degree endoscope, because you will not be able to advance it in enough to make the angle. So you need to have a 3mm 30-degree endoscope. Otherwise, you will not be able to, otherwise you would be looking at the ear canal. So if you're using a 4mm 30-degree endoscope and you put it inside the ear, you won't be able to advance it enough to look at sideways at the different middle ear spaces. You'll be looking sideways at the ear canal. So 30 for endoscopic ear surgery, if you're using a, you want to use a 30-degree endoscope, you need to have the 3mm one. Again, no shorties. Of course, everybody now operates off the video camera and monitor. And I really think, like if, I think you need to get some basic dedicated instrument. And we're talking about the suction instruments. And I've, again, fallen in love, really. The two things that have changed dramatically in my practice of endoscopic ear surgery over the years are the use of angled endoscope and use of suction instruments. And I really nowadays, I look back at and I'm like wondering, how did I do it before without angled endoscope or without suction instruments? So this is the one that I love. This is a Panetti suction instrument set. And this is the one instrument that you really, really want to get. And I'll show you some videos later of this in action. It really is a tremendous, tremendous instrument. And it really adds to your ability to carry out the surgery in a very delicate way. And it's a very, very nice instrument. And again, I will show you videos at the end. And I operate sitting. Some people do operate standing. This is really an old picture you can see from the monitor. This is probably like almost 25 years ago. And I usually like the nurse to have access to the monitor. But what I'm trying to say here is that you really don't want the monitor up here. Otherwise, your neck would feel very tired at the end of the session. You want the monitor to be in this area here. And of course, if you're not using suction instruments, you have to alternate between suction and instrument with your right hand and use the endoscope with your left hand. So the first sort of practical advice I have for you is that do not float in the canal. A lot of people want to hold the endoscope like in the middle of the canal, and that really does not work. So don't go around, like this. This is the red, I guess, is the endoscope, and the blue is the ear canal. So I usually anchor the endoscope towards the back of the ear canal. And I find that very useful in terms of the stability of the image. And I find it very, very useful because I straighten out the ear canal. So I could introduce instruments in this space, and it aligns. If you push down on the cartilaginous ear canal, you end up aligning the bony and the cartilaginous ear canal. So when using a 30-degree endoscope and you want to look at the retrotympanum, you basically put the 30-degree endoscope at the interior end of the canal, and you look at the retrotympanum with a 30-degree endoscope. If you want to look at the attic area, you put the endoscope, 30-degree endoscope, inferiorly towards the bottom of the ear canal. So it's always target tissue, instrument, endoscope. Target tissue, instrument into space, and endoscope. Target tissue, instruments, and endoscope. So steps and tricks. basically, you know, since we're talking canal access, you really need to have a plan for your ear canal, and you really need to think about your access in a much more. You have to give the ear canal a lot more thought than you used to do with traditional microscopic surgery. And the need to consider, you know, like how you want to remove the bone, removing disease, and you need to think the areas that you want to visualize, and then ultimately reconstruction. So improving ear canal access is critical in endoscopic ear surgery. The most important point that I keep on mentioning is you need to align the axis of the ear canal, of the cartilaginous ear canal with the bony ear canal. And you really have two choices. The first one is to do like a tympanomeatal flap and basically gain access to the disease and remove it, and then replace your tympanomeatal flap. And the other one is to basically do almost like a Sheehy's lateral graft technique, where you basically preserve the vascular strip. You remove the skin of the ear canal along with the epithelial layer of the tympanic membrane, and you take them out as a free graft and you reposition them at the end. And after you take out the skin, you basically could do some bone removal, drilling, enlarging, canalplasty to improve your access point. So this is a point that was mentioned yesterday by Anil. It really, really is important to do a very wide tympanomeatal flap. And I would say the two limbs of your flap, tympanomeatal flap, should really be almost parallel to the annulus. So you really need to go very, very far anteriorly. And this is a point that I'm trying to make here. So basically, again, this is I guess this is a cholesteatoma. This is a very old video. I have some new videos at the end that I will share with you. But you can see how far I'm going in theory, almost like to 1 or 2 o'clock, making the turn, and then going really almost ending up parallel to the annulus, very, very anterior. Now, I just want to make one point here, in that you see that here I made the tympanomeatal flap quite long. And I have to tell you that I changed this. This is clearly a cholesteatoma. Now, when I'm doing a cholesteatoma case, I really make a very, very short tympanomeatal flap. I basically just put it like 2 millimeters away from the annulus or the rim. And my thinking is that when you're doing a cholesteatoma, first, you know, you need to reconstruct anyway. So it's not a big, even if you have a bit of a shortfall, and you could address it by putting some sort of facial graft. But the most important issue is that if you do create a huge tympanomeatal flap when you're doing cholesteatoma, that tympanomeatal flap has, you know, when you're taking out the cholesteatoma, has to be tucked somewhere anteriorly. And what happens is that you really don't have much of a space to tuck it. And when you have a lot of soft tissue there, the soft tissue ends up bleeding, creates a messy field for you. So and chances are as well, when you're doing a cholesteatoma removal and stuff, you end up traumatizing this tympanomeatal flap and end up really losing all of that flap altogether. So for cholesteatoma, I do a very, very short flap. And even if that flap, you know, because I know that I have to reconstruct it anyway. But in cases of tympanoplasty, yes, I do a very substantial, longish tympanomeatal flap. So this is what I call the lateral canal axis, and it is basically do this for like large perforations, and you do this for cholesteatoma, for Peters-Avery disease, if you have a small ear canal. And again, it really is the Sheehy's lateral graft technique. So you basically outline the vascular strip. and you basically create, do the ear canal cuts. So the plan is preserve the vascular strip and take out the skull skin of the ear canal as a free graft, and at the end to replace it at the end of the case after you've either enlarged the canal or did your reconstruction. So I'm basically elevating the skin, and this now is very, very easy with suction instrument. It used to be reasonably difficult, but you basically am elevating the skin of the ear canal. You see I'm leaving the fibrous layer of the tympanic membrane. I do the stucking quite a bit. I think it's really a very nice way of figuring out the planes of the tissue. So this is the tympanosclerosis. You can see that I've taken out all the skin of the ear canal along with the epithelial layer of the eardrum. And then I enlarge the ear canal, make sure that I don't have any hidden sulcus or areas. So this is the other approach, and this basically again gives you a much wider access into the disease and into the middle ear cleft. This is what I was mentioning, is that you really don't want your scope to float around. What I used to do before is basically really push hard with the endoscope on the cartilaginous ear canal in order to straighten or to align the cartilaginous with the bony ear canal, because most of our, of course, instruments are straight instruments, so you have to create a straight axis port for yourself to introduce the instruments into the ear without really traumatizing everything on the way in and the way out. And this is something that I'm doing more and more. This what I like to call the Torabishi retaining suture. Basically, so you can see here that if you're sticking the endoscope, there's a hair here, and so the endoscope and the way in and the way out is going to get smudged. And again, there is really a very different angle between the cartilaginous ear canal and the bony ear canal. So what we do is we put the stitch just beyond the cartilaginous bend, and we get it from the back side. And so the idea is this, and the idea is to straighten the ear canal. It's a retaining suture, basically. So, when talking about colostoma, we know that the tympanic cavity is the sort of the domain for the endoscope, and we know that the mastoid cavity is the domain of the microscope. So we start endoscopically where the disease starts, basically within the tympanic cavity, and pursue it to the attic, anteriorly to the eustachian tube, hypotympanum, retrotympanum. All the tympanic cavity is basically an endoscope area, and the postauricular area, or the mastoid, is a microscopic area. So when we leave it to the end, because it is by far the least important, I think. So this is basically what you do in elevating tympanomeatal flap. This is also a very, very old. So you take out the bone as you go, trying to expose the sac. And you can see the sac here, the chorda has formed almost like a neck around the sac, and I'm putting the sac back. And I do again a lot of this tugging and pulling, trying to preserve the sac. So I'm trying to pull the sac out. And it has rotated around the incudostapedial joint. So I'm putting it out of So this is left ear again, showing how to remove disease. So of course, this is a very normal tympanic cavity. This cholesteatoma is up here. It's chorda. It's the left side. So removing the bone with the curette, trying to get as a cholesteatoma. And again, a lot of times I try to define the cholesteatoma away from the bone edges and really do this skin pulling technique. I find that it ends up removing a lot of cholesteatoma, even in hidden places, just by tugging at it, and really be patient. Don't tug, hold it, and just pull. Just give it time to work itself out. Again, this is the left ear. You see the staves and lateral semicircular canal. So this is the other ways that I find myself using, taking out the bone is basically with these small osteotomes that they use in steroidectomy. I find it to be very, very effective. And it really has two advantages. So the first one is that you could put it right over the chorda and think that they're going to cut the chorda, and the chorda is never cut with these osteotomes, basically, because what it does with the chorda moves with the osteotome, and the bone is the part that does not move. So it really is very, very safe for chorda. I guess that's why they use it in stavy surgery. But it could be a very, very effective way of removing the bone. Like see here, I'm really going over the chorda, but still the chorda is intact. So you can see that I've taken some nibbles of bones. The other advantage which is more important than the chorda, is the fact that when you do this, it really preserves the sac. So basically, you take out the bone, and without really cutting into the sac. But if you're using a curette, you end up basically removing the sac with your curette. But here, and you'll see that in just a second, it really creates a very nice sort of cleavage between the bone and the sac. So if I was using a curette here, I probably have taken the sac away with it. But here, I'm basically just peeling the bone away, and you could see the sac behind it is intact. And this really, it's a nice, this is how endoscopic ear surgery is supposed to work, where you really, see the planes, and you see the pathology in a very, very clear manner. You see the chorda tympani here, and you see the cholesteatoma, the mesotympanic cholesteatoma behind it. Again, I'm really in love with these suction instrument sets, and sometimes when you're in the attic, I use a really angled this suction instrument that could take cholesteatoma from really deep within the attic. But because it's sharp, I usually use it always with the with some sort of a pledget to make sure that I don't harm anything. And what I usually do is I introduce the pledgets into the normal area and push with the pledget, and you can see basically I'm folding the cholesteatoma away from the mucosa. And so this is really, talking about preserving, talking about the way to do surgery is preserving mucosa, preserving function, and this is really what the endoscope allows you to do. In terms of reconstruction, of course, when we have significant episiotomy, this is the cholesteatoma that has eroded much of the head of the malleus. Use these open book grafts, excess pericardium, and they do work very well in terms of closing the attic defect. I have to tell you that I am a lot more conservative about creating big attic defects. So if I'm thinking, it's not like I'm gonna go and pursue the cholesteatoma no matter what through the ear canal. If I believe that I will have to do a mastectomy, I really quit pursuing the cholesteatoma with episiotomy very early on and really get everything from the back, because I really think there is some advantage to having the scrotum, a bony scrotum, basically holding up and preventing any further retraction. In terms of reconstruction, this is again the reconstruction for the lateral graft or the lateral approach technique. I use this Surgiflow, and it really cuts down on my packing time. Surgiflow is basically almost like gel foam. It really is just gel foam, and you basically just could basically inject it into the spaces that you need to pack it with gel foam. So this is the way I do it. I fill up all these spaces. This is again after I've taken out the skin. Make sure everything is smoothened out. But the pericardium is a lateral graft. I usually, I have to say that I stopped tucking it under the handle of the malleus. And I'm not really seeing a huge advantage to that. I'm not having any lateralization or anything like that. But this is sort of done the old way. And then I find this, I fold the skin of the ear canal on a piece of gel foam. It allows me to introduce the skin back into the ear canal in the right way. The most important issue is not to put the wrong side up. So I always do this under the microscope. I fold the skin over the gel foam, and the idea is that I want to make sure that I've lined up the skin well, and I did not put the wrong side towards the bone. And then I pack the ear canal. So just gonna, I think, a lot of people are just mainly interested in endoscopic tympanoplasty, and just have a few words about this. With tympanoplasty, we're basically establishing a platform for the eardrum to go over. So really, surgical trauma is part of the treatment, because what we're trying to do is stimulate the growth of the healed over eardrum. That's why we refresh the edges, and I really think that if you try to really do minimally invasive stuff, like for example, not elevate the tympanomeatal flap, you end up really with a very poor outcome, because part of the ways that we're stimulating the ear canal to heal is by elevating the tympanomeatal flap. And I really think that's sort of the best way to create a tremendous amount of surgical trauma to enhance, release all these all of these inflammatory mediators to stimulate the closure of the perforation, is really the lateral graft tympanoplasty, where you take out all the skin. And I think that has a tremendous way of stimulating the ear canal, of the skin of the ear canal to grow over the graft and reconstruct the perforation. So the endoscope really brings a bird's eye view of all the elements of the surgery. Basically, the perforation and the ear canal and the graft. And I cannot really I cannot remember, maybe for the last 15 or 20 years, I have not done a post-auricular incision for a tympanoplasty. The one of the and this is the area that I'm using a lot more 30-degree endoscope, especially anteriorly. And what I always want to see, if this is the perforation, I do this very, very wide elevation of the tympanomeatal flap, and I consistently remove or separate the tympanomeatal flap from the handle of the malleus. And I think this really allows me to layer the tympanomeatal flap on the ear canal wall. And what I want to do before I would start my reconstruction is see the anterior edge of the perforation from behind the tympanomeatal flap. So I want to lift up the tympanomeatal flap, layer it against the ear canal, and really see the anterior edge of the perforation, usually with a 30-degree endoscope. And this is the case. You can see how widely I elevated the tympanomeatal flap, and I'm seeing the anterior edge of the perforation here. So in this situation, I really could do a great job elevating, a great job making sure that anteriorly I'm fine. Oh, this is the eroded joint. I find myself nowadays using a lot more bone cement, but this works also. The apple bond prostheses, it really works very, very well. But sometimes when there's retraction, it's very hard to reconnect. I always stuck the graft in between the end of the malleus and the tympanomeatal flap. So the major issue with the lateral graft technique is that if this doesn't work, nothing else is going to work. And there are some times nothing works. The endoscopic lateral graft technique is an ear canal operation. The nice thing about lateral graft is that you're really not fooling around with the middle ear space. So basically, it's an ear canal operation because you're taking out the skin of the ear canal and you're laying it at the end. You're not really interfering with the middle ear cavity. But it does have a long healing period. Sometimes you get the granulation tissue. And sometimes you look at it post-operatively and you think, really, this doesn't look good. Fortunately, the patient also doesn't look at it because the hearing results is good. It does not look good to inspection, but the hearing results are really good. And I have noticed, and I don't know if maybe I'm interested in hearing from the audience, I have noticed that in many, quite a few cases, it creates more opportunities for fungal infections in the ear canal later on. So I think somehow it takes away the natural immune system that prevents these fungal infections from the fungus from going in the ear canal. I've noticed it quite a few times where after lateral graft technique, the patient is having recurrent fungal infections in the ear canal. Again, I'm very interested in if other people had the same observation. What I want to show you now, I want to show you some pictures of using the suction instruments, and I think you're gonna like what you see. Let me just look 1 second. Let's get the picture in 1 second. All right. So this is the first video that I want to show, and you can see that I'm using this angled instrument that I talked to you about. I'm elevating the tympanomeatal flap, and you can see how wide flap I have, and this allows you to suction at the same time. It's a very, very nice instrument. Let me just show you another, no, not this one. All right, let's see this one here. So this is a sort of attraction and cholesteatoma. It's a left ear, and just doing my just suctioning the ear out. You see, notice that I cut the hair really nicely, and again, this is the left side. You can see the cholesteatoma, and this is a child. This is an 8 years old child. So doing my tympanomeatal flap, and in this instance, again, this is a recent video. This is like 6 months ago. You could see that I'm doing a very short tympanomeatal flap because I really want to tuck. I don't want a short flap that I can tuck it in anteriorly while I'm working posteriorly. And you can see how wide the tympanomeatal flap is. Like, see the other limb, it extends really anteriorly, almost parallel to the annulus. See how far I'm going in? So once I make the cuts, I usually use a lot of pledges. I always have 2 or 3 pledges. I use a lot of irrigation. All of these are very, very helpful in these cases for endoscopic ear surgery. This is these are soaked with epinephrine. And one of the things that, again, we already did is that this live surgery, and so it's reasonably very successful, actually. And we're going to be having it, but you really need to download the app so you could basically be able to book your space for the live surgery. You can see how I'm using the suction instrument. And again, I think if this one instrument would be, I think it's very, very important to have. The rest, there's a wide range of suction instruments, but this by far is the most important one in my hand. So I'm just finishing up the cuts. See, 2 or 3 pledges at a time. And the nice thing again about this suction instrument is that it allows you to, let's see here. Yes, this one. This is the one. Okay. So you can see how this, again, this instrument, you're using it to separate the eardrum in a very delicate way from the handle of the malleus. This is the left ear. You see the handle of the malleus here, short process, tympanic membrane. You can see how the tissue really. It's just that this instrument, the angle of the instrument is designed for this basically. See, I'm unfolding the tympanomeatal flap away from the. And the reason I do this almost in every case is because, again, I want to layer the whole eardrum against the anterior wall of the ear canal. So I want to have an extreme access into the anterior eardrum. You can see how you could really go around the short process with this angled device. So it sucks at the same time that it's doing its dissection. I have to tell you that I have not had too many recent videos edited and stuff. Actually, I edited this video just this afternoon. But really, the way I recognize now that the way I'm doing surgery have changed a lot. So I need to go and really redo all of my presentation to show the sort of the different way that the suction instrument and the angled endoscope have changed my my practice. So if you do that again, you have tremendous access into the anterior tympanic cavity. Let me see. I'm missing one of these. Let's see, this one here. No. This one. No. Anyway, so you could. I think I showed you this one. I'm missing. Anyway, I think I'm missing one more. This one? No. Anyway, well, I think so. I'm pretty much done here. So I promise again. I keep. Let me see if let me see if I could look at the chat line. And if somebody wants to like speak, I could open up the microphone for you, but you need to wave your hand so I know that you want me to open up the microphone. What in my opinion, what prevents the fogging of the endoscope? The most by far the most important thing is the. Let's get my face on there. By far the most important thing is heat. The endoscope has to be hot. The irrigation has to be hot. The sponges, I always tell the nurses to soak it in warm water. So you really have a cold room, cold situation, cold irrigation, you will go crazy with fogging. The other thing that I think you might want to observe is that sometimes, now of course, I have to tell you that for most of my career, I thought that chronic ear surgery meant basically, obstructed or station tube. But I've been recognizing more and more that a substantial group of our pharyngocytoma cases are basically passulus or station tube. And the patient is really sniffing and creating negative pressure, which creates the retraction. So, and I would say this probably represents 20 or 30% of our patient population. But in these cases, and if the anesthesia is having a bit of a leak, what happens is that the air comes up through the eustachian tube, and you have continuous fogging of the endoscope, and it really is almost impossible to operate. So that's why in these cases I do apply a piece of cottonoid, and I try to plug the cottonoid with epinephrine. I try to really plug the eustachian tube or the pertympanum temporarily while I'm doing the surgery to prevent the fogging. What is the whitest solution? Yeah, it's basically liquefied gel form. It's called surgery flow. And do I prefer to close with pericardium or cartilage? I basically, posteriorly, I always close with composite cartilage, the area that we always see retraction in. So in between the posterior annulus and the handles malis, I try to close it with composite cartilage. And anteriorly, I always close with pericardium. So does the elevator have a suction attached to it? Yeah, that's what, again, this, and I really think if you get that one device, one instrument, you really, Panetti instrument set is overdone in that there's so many angles and so many shapes and so many stuff that you really don't need. It's just costing you money. But this one instrument that I showed you, you gotta get it. It really is very, very helpful if you want to do endoscopic ear surgery. Light fighter bite is always needed. It doesn't make any difference in your picture. Yes, this is the Muhammad Badruddin. Thank you, Muhammad, for joining us. By the way, Muhammad, if you want to have a comment, please let I could open up the microphone for you. So you could wave me, give your hand, and I could do that. So basically, yes, you need to have a lower setting. We're not talking about sinuses here. We're talking about the middle ear cleft. It doesn't take much light to gain access. Advised by resting inferior to look for the attic mini posterior. What's your light power? Okay, we answered the question about the light power. After 360 degrees elevation of canal skin, will it cause lateralization? I really have not seen any lateralization or any blunting, and that's why, honestly, I stopped tucking the graft underneath the handle of the malleus. And I really think it's a function of, when you have this tremendous access with the endoscope, you could make sure that the graft and the skin is tucked right on the bone and supported with some gel foam. Some had lost the usual anatomy tympanic handle manuals. How you know whether it's right? I should have pointed out. I hope that I did not confuse you regarding whether it's right or left. Role of an assistant, I don't see any assistant role really. I cannot see the assistant being helpful at all. The direction of the curating, of course, you want to curate, the scrotum, you want to curate away from the ossicles. So I guess basically it's clockwise rotation. Can we use separate? Again, you could use separate. You could use regular instrument, but get like 1 or 2 suction instruments set. Did you see any? I did not see as a video demo any anterior hump where those being drilled. I mean, that's really the whole idea of using the endoscope, is that you're really going beyond those humps. Very unusual for me to do any taking down anterior humps, but really with the endoscope, especially with 30-degree endoscope, you basically end up with no humps because you're really seeing beyond that. Any anesthetic gas to be stopped during placement of graft? I don't ask. I know that when we were young residents, they used to routinely ask anesthesia to be aware that we're putting the graft, but I just don't see it being an issue anymore. What's the name of the instrument? It's again, I don't know the name of the individual instrument, but it's a Panetti instrument set, and you will recognize it on the catalog. For the lateral flap, what is the maximum canal skin can be removed? Well, it's just you have to remove the skin completely of the ear canal. And Muhammad agrees that. Muhammad, maybe I'll get Muhammad see if he has some comment. Muhammad, you want to say something? Muhammad?
Hi,
how are you? How are you doing?
Yes, I enjoy very much your presentation and talk. It's very illustrative, and
thank you.
That's actually here.
Any advice for the group? What are you using suction instruments day in and day out, or you're not using them?
Yes, definitely. I admire very much the Panetti set. It's a great. Panetti has many instruments. Yet I agree. You sometimes they are quite expensive, so you may need to choose one or two of the sets. The one you are using is very important, and it's important because the one you choose, Moaz, had got a very good angulation. It's not long, so it's neat for someone who doesn't have that. It's better for him to ask someone like, for example, you, what is the best if I need to choose one or two, okay? Because he has like 10 of them, okay? And unless the institution will buy the whole set, okay, he will have just to choose. And the one you are showing is very good as angulation, as the length of its angulation, and as it's seen, you can dissect nicely. Yet with experience, you may not need those suction, because you can do it with whatever you need. So it's only a matter of it. But I believe that this is important for the instrumentation. And also there are now many companies making those instrument sets, not only the Panetti, but you'll find many companies like the Stores one, other like Micro France, the new company, I can't remember its name. They are all doing this instrumentation. Moaz, I liked very much the osteotome, and these small osteotomes are not easy to find now. So from where did you get them? Not from Japan. I know CG Kakeheta is using them, but I don't know where you got it, because CG has a whole set. And old in France, I know that my old professor, Jean-Marc Cerquez, had a full set of osteotomes, but this is before the drilling. Now, from where did you get the osteotome? I would love to get one or two.
Okay, well, I actually got it for free from a very, very good friend from Mumbai, Ashish. You know Ashish, right? You know Ashish from Mumbai?
Oh yeah. Okay. I know.
So
yes.
Ashish actually was I saw him doing it, and I said like, this really looks nice. Where do you get it? And after 1 week, I got it in the mail. So you want to ask Ashish? He's a very generous guy.
I'll do it. The last point, there was a question about removing the 360 degree of the skin. How can you avoid the blunting of your graft if you are doing like a total perforation or something? Can you comment on that? About you mentioned removing 360 degree. I always try to keep even a very small part of the anterior or anterior-inferior of the annulus. It will help me to put my graft under the annulus anterior to avoid any blunting. What is your technique in that?
I think basically access. I think with the endoscope you have a great access, and really you could tuck things very well. But I have to tell you again, I mean, as always, we all thinking, oh wow, it's gonna lateralize or gonna be blunting, but I haven't seen that. And I think it's just the access allows you to better tuck that graft and skin in the right place. Thank you. It's nice to see you. We haven't seen each other for a long time.
Thank you very much. I enjoyed it very much. It's very nice tips and surgical skills. Thank you very much, Mohan. Thank you.
By the way, Danielle got in touch with you, right? Or regarding the
yes. We will have a panel discussion altogether soon.
Sure. So the IWG's board will basically, and we're calling it wins and regrets. So we're going to talk about our regrets as well.
Yes,
In terms
yes.
of the use of endoscopic technique, and you'll find it again on the website. I keep asking you, please, to download the app. Again, it allows us to communicate with you and give you the information. And as we progress further, it allows you to get CME credits as well, because we're in the process of doing that as well. So please, if you haven't downloaded the app, go ahead and download the app. Thank you very much. Tomorrow we have real authority in the area of thyroid disease joining us. Mike Leferio is the head of endocrine surgery at MD Anderson Cancer Center. He's going to give us like he's going to give us an update about how we manage the thyroid nodules and well-differentiated thyroid cancer in 2020. So everybody has a nice evening, and I'll see you tomorrow. Thank you.
Thank you.